I'm introducing the first speaker for the second session. That's Dr. Chuck Alejos, as we all know him, but he's the director of our pediatric heart transplantation program and heart failure program at UCLA, has been doing this as long as anyone can remember, and is an amazing clinician and has an experience that is really worth listening to. So Dr. Alejos, please come up.
Hi, thank you, Reshma. Actually, she's right. I can't really remember how long I've been doing this. So, good morning. I actually got a real small topic to talk about, so I'll try to get the pre, post, and assist devices and pediatrics covered within 20 minutes. But no, seriously, this is actually a kind of an overview. I know you're going to be getting some talks later from Dr. Reamston, who are going to cover some of the areas, so I'll try not to overlap too much with him. First, just a picture, obviously, of home. Kind of makes me feel a little comfortable before I start speaking. But then, again, I guess I'm not that old that I was there when the first transplant was done. But again, it's very important for us to always remember where where transplantation started, and the very first patient who underwent a transplant back many, many years ago. And again, not to make too much fun, but we want to just start with a little bit on the lighter side. Here, just how cardiologists and surgeons perceive themselves, but just never know. Anyway, going on to actually the real meat of the issue, pediatric transplantation has actually, always been, by volume, much smaller than adult transplantation. But as you can see, starting back in 1982, the volume across the country, this is on a national level, of pediatric transplant has actually kind of continued to increase across the board. UCLA, this is a little bit of a dated slide, but just to give you, again, the general idea back from 1984 when UCLA did its first pediatric transplant, that our volumes have continued to, to increase significantly. This is basically, this includes both pediatric and adult, but you look at overall, the portion, the yellow portion in there is actually the part that represents pediatrics, and our percentage has continued to increase. Now, indications for pediatric heart transplant are a little bit different than they are for adults in the sense that, our patient population varies quite a bit, and especially, some of the more, the bottom line is, much like as an adult heart failure or cardiomyopathy, the indication is really end-stage heart disease that's refractory to basically what's called conventional medical or surgical therapy. And that's the important word, conventional, because anytime we talk about an intervention, there are many things that people can think about. That's why I'm fortunate to work at a place like UCLA, but you have some great minds there that kind of think outside the box. But really, to consider transplant, you really have to look beyond what people would consider conventional. The most common indications for transplant include, the idiopathic dilated cardiomyopathy. It's a field that, if I had more time, we're really delving quite a bit more into getting rid of that word idiopathic and actually finding the true causes of the dilated cardiomyopathy in many of these patients. Congenital heart disease plays a growing role in that, both in the preoperative and postoperative phase, as transplantation is now is basically considered in many cases, a part of the pathway in many types of palliative surgeries. Non-malignant cardiac tumors, that's, again, very rare. I don't think I've ever seen it in all the time that I've been here as an indication for transplant. And intractable arrhythmias, and thanks to all the hard work done by our electrophysiologists, arrhythmias really, there is really very, very few patients that have arrhythmias that are so untreatable that they require transplantation. As you can see, the pie in terms of at UCLA, what makes up our population. UCLA is rather unique if you look across the country in terms of our patient population. About 50% of our patients are dilated cardiomyopathy, while, again, about 10% were composed of restrictives and retransplant. But what's interesting or what's unique about UCLA is congenital cardiomyopathy, or patients with congenital heart disease, make up almost 45% of our population. And that's very unique if you look across most programs, because most programs do not face that that kind of a number. And these patients pose quite a few different challenges in terms of transplantation, not only in anatomical, which you'll see in a little bit, but also in much of the preparation of getting these patients to transplant. So I think that, UCLA is unique in the sense that our congenital heart programs are so strong that we attract a lot of these patients when they do end up needing transplant. Here's just an example of some of the most common diagnoses in terms of congenital heart disease that lead to needing transplantation. The most common is a single ventricle. The single ventricle patient essentially is a patient who has, who was born with essentially what people call half a heart. Or really one chamber pumping and doing the work for two. And despite excellent advances in terms of developing palliative procedures, many of these patients, by the time they end up getting to their teenage years and into adulthood, end up requiring transplant. These same palliations that we do in order to get them out as far as we can are what lead to some of the challenges in terms of reconstruction that makes congenital heart surgeons kind of, a must when you consider transplant for these patients. But also some of the other lesions which are much less frequent, but transposed great arteries, which is basically, blood vessels that were arising from the wrong chamber when the patient is first born. And at birth, they usually undergo what's called an arterial switch, which essentially switches those arteries back to the right position. But they also, form quite a bit of a chunk of the population that goes on to transplant. Just an example, again, you can't be a pediatrician or a pediatric cardiologist without showing off your patients. And so these are some of our patients, and actually we use this slide. All these girls here have undergone transplant, and as a result, after showing this slide, I got a bunch of teenage boys that wanted a transplant, but I told them that was not possible. But just to, again, I use this more, truthfully, to show, a lot of teenagers, both who we talk to about organ donation and about transplantation, they have an image of what happens to you if you become a transplant patient. So this is basically to show them that you don't become a monster, you don't grow a third eye, nor do you, because you really grow up to be, kind of a normal life, which is a whole goal of transplant. Again, this is not LA, it's not the 405, but it could be after this morning, I think it's, but this is basically how confusing transplantation can be in terms of, the path from being referred for evaluation to actually getting listed and going through a transplant. It can be a mess, and there's a lot of things to be considered. What we wish was this is what we would see every day. Unfortunately, especially in pediatrics, it's far from this. When we talk about evaluating patients with cardiomyopathy, really what we need to decide is, does a patient need a transplant? And we have to study the medical and surgical options before we decide, before we can answer that question. But that's very important. We have to determine, does a patient really need to have the transplant? Then we have to really ask ourselves, does the patient, and what makes it unique in pediatrics is, does the patient and the family or the parents wish to undergo a transplant? And that can be affected by religious beliefs, by quality of life issues, and by, the follow-up. And the quality of life issues, for a family, there are some families, it's very rare, but there are some families who don't want their child to be tied to a hospital, coming for lab tests and coming for biopsies. And but for the most part, really, the only patient that I've had in 25 years who's told me she doesn't want a transplant is a little girl who had rheumatoid arthritis as well. And she asked if her transplant would fix her arthritis, and when we told her no, it wouldn't, she really felt like that was not the quality of life was not going to be what she wanted, and she chose not to have a transplant. But there are people, we have to offer it to them as an option, because obviously if the patient family does not want to care for a transplant, then the success of it will obviously be severely impacted. Looking, are there any medical, surgical, or social contraindications for transplant? Some of them anatomy. As you'll see, I'll show you a few slides in a little bit about some of the complicated cases we face. Hemodynamic data. Patients who have, conditions, pulmonary hypertension, that make them poor candidates for just a heart. Antibodies, which is something we struggle with all the time, and patients who form antibodies against other people's DNA by getting blood transfusions and being exposed to that, makes them a higher risk transplant patient. And then the big question for us is, there someone who will care for the child into the future? You can transplant a child, but if no one's going to be there to help care for them, it really makes us concerned about how well this is going to succeed. I mean, as I mentioned, looking to see does the family or the patient really want a transplant. We talk about risk versus benefit, quite a bit in terms of transplant. We try to explain our goal overall is to get these kids to have as normal a life as possible, to be able to go to school, to be able to grow up, graduate from high school, have girlfriends or boyfriends, and basically have as normal a life as we can. But sometimes what they have to go through is a very difficult path. Follow-up and medications. We explain all this to the family because medications are, a big deal. It's, most of these kids go home taking, 13 to 15 medications 2 or 3 times a day. And when they're little, the parents have to bear that burden. But when they become teenagers, that's our most difficult, patient population. These teenagers a lot of times feel, even if they've had a transplant, feel that they're indestructible and that they don't need to take their medications or that they can skip a dose here and there. And that actually really has a huge impact on, on the risk for transplant. It's actually our most at-risk population. Some of the things our surgeons have to be concerned about is anatomy, as well as the cardiologist, is the anatomy of these patients. If their heart is in the right side of the chest instead of the left, getting a donor can be very challenging, or making that heart fit into the, into the existing chest can be very difficult. Some of our, well, again, I'll show you shortly, but other end organ disease, we worry about the kidneys, the liver, and most importantly, the brain. In some of these kids, if they've undergone a cardiac arrest and we're concerned about their neurologic outcome, can we do the surgery? Yes, but will that be the child that they knew before? And we don't know that. It's a very difficult question to answer in many cases. And then other medical conditions that limit life expectancy and hemodynamics, are pressures in the heart that affect our decisions. Kind of going through these quickly just to stay within my time. Renal, kidney function, liver function, some of the things that really are important for us. Psychosocial issues, we have to wrestle with this. Is transplant a right or a privilege? That's a question that both adults and pediatrics have to wrestle with quite often. And then again, if parents are irresponsible, then should the child suffer for the fault of their parents? That's a very difficult situation, but if we have a 2-year-old whose parents are not going to be reliable, what do? Do you punish the 2-year-old because his parents can't? And that's a question we wrestle with quite a bit. And then how should the state get involved? Well, they used to be quite helpful, but more and more they've backed off in trying to interfere with parental rights, so it really gives us very few options. Just to give you an idea, this is actually some of the hearts that we see. This is actually a heart before transplant. So this heart's in the right side of the chest. It has those connections are all, backwards and again, far from normal. And so this is the type of transplant that they sometimes have to do. So you can see with all the stitching, there's quite a bit of reconstruction there that has to be done. And again, a congenital surgeon is a person most skilled. So Dr. Reemston, I turn these hearts over to you or Rashma quite often and quite happily, because it's something that takes quite a bit of imagination and skill. Again, other areas in transplant that we have to wrestle with, this is back in 1984, but for those of you like me who are old enough to remember baby Faye, this is a baby who at Loma Linda received a transplant from a baboon with a baboon heart. Now, this baby died on 20 days post-op, but the cause of death was infection and not rejection of the heart itself. So this is an issue that will come back to face us again as we struggle with lack of shortage of organs, and it's going to be, again, a hot ethical topic, but this is something that will come back in the near future, I'm sure. Just to give you an idea, again, risk factors. We're going to talk a little bit more, and Dr. Reemston is, and I'll kind of fly through these a little bit. But the use of ECMO is the highest risk factor. ECMO is basically extracorporeal support, or an assist device, the most complex assist device that we have that we can use from a newborn on up. But that is the biggest risk factor for mortality in these patients as well when you get to needing that. Congenital heart disease also is a significant risk factor. So as you can imagine, these patients obviously for us are pose quite a challenge. We have the challenges with immunosuppression for these children. We have to actually find a happy medium. If we over-immunosuppress them, they are at risk for cancer or other infections or having toxic effects to their kidneys and liver. If we under-immunosuppress them, they're at risk for rejection. So somewhere in the middle, we have to find a nice balance between the two. And again, I mean, so I can catch my breath, just to show you a couple of other, some of our other successful transplant patients. So some of these guys, again, I mean, have done very well. And I mean, overall, I mean, for us, success is to know that we've even one life has breathed easier because we've lived. That is to have succeeded, and then actually it's a creed that we all live by. I mean, we're here for our patients, and hopefully, I mean, we can consider ourselves to, I mean, on every day, at the end of the day, we can call ourselves a success. Now here's other problems. I actually, for those of you who can't see that at the bottom, it says, "All right, so he dropped the heart, the floor is clean." This is, and I won't say that I've seen this anywhere, but that's just, to throw that out there. One of the big reasons, I mean, this is actually a study that came out just recently looking at the number of children who die waiting for transplant according to weight. And so it shows you that there's quite a significant in the lower age range or lower weight ranges that die waiting for an organ, and which has led to kind of a lot of work being done in an area which I'll touch on briefly because Dr. Reamston's going to be covering that quite a bit later, but using support assist devices much as the Berlin heart, which is, the Thoratec left ventricular assist device, some of the devices you see kind of pictured here. There are other options. I mean, we use something called the ABO incompatible, which is we use in children under approximately 18 months of age. And what that means is that at that age, children have not built up enough of an immune system to combat a blood type or a mismatch in blood type. So you can transplant from any blood group to these patients. And that's something Dr. Reamston will talk about a little bit more, but it does offer us a bigger donor pool potentially for infants. But as you get older, obviously you build antibodies, and that's not possible. So ECMO is, basically, as I said, it's like going on bypass on a heart-lung machine. It has a lot of complications associated with it, and typically our average survival on ECMO is about 7 days. So as you can imagine, the chances of finding a donor in those 7 days is slim, and the problem is also you need to be paralyzed and sedated, so assessing their neurologic status of these patients is also very difficult. So overall, we consider it a poor long-term solution. Ventricular assist devices, have been fantastic because they do provide both right ventricle, left ventricle, or biventricular support. And the nice thing about them is that actually patients in theory can go home with them. However, our biggest problem is that there are very few that work or fit a pediatric patient, which is what we're, struggling with. So, looking at this is, again, a simplified version of an ECMO pump, and again, Dr. Reamston is going to cover this more. Overall, looking back, in 2010, we did 30 cases of patients on ECMO ranging from 1 day to 15 years, and that was in 26 patients. 19 of them were able to come off. A lot of our ECMO success is a credit to our perfusionists, being at the bedside and the nursing that we have. So just to give you an idea, ECMO can succeed in the right hands, but again, overall, not a tool that we really want to, use too much. This complex chart I will leave to Dr. Reamston, but it basically describes all the different types of assist devices and in which category they would be used. The HeartMate 2 is something that's newer, but again, it's really only used in our teenage population, in our larger teenage patients, so that, and used basically entirely on the left side of the chest. Recently, we've actually sent home 2 patients who have actually gone home with the HeartMate 2 while they wait for transplant. So, actually, it's a nice option to get some of these kids out of the hospital. The Thoratec, again, as I said, can be single or biventricular, and again, this is all for the older patients, the teenage patients. The Berlin heart, which actually we can use down into the infant years, is a great option. It's probably our best option. It's not a perfect option. There are a lot of risks associated with it that include bleeding and stroke, but I think we're finding, we're aggressively working on how to deal with those. But at present, it's our best option in the newborn population. So I'm just gonna, again, I think I'm going to end with some pictures of patients. These are some of our patients who've been on the Berlin heart. As you can see, their little girl at the very bottom has, her pumps on. So these kids can be extubated, can be eating, can be held, can obviously play dress up. But again, it is truly a great option. I mean, I'll leave the total artificial heart to Dr. Reamston because that's actually the newest thing, and my timer is going to kick me off the stage in a few seconds, so I figured I'll leave you with that. But overall, I mean, pediatric transplant has come a long way. I mean, we've strived to really do our best to provide the best care for our kids, and I hope that we can feel that we do. Thank you.